Hi everyone. So we're going to go ahead and um, talk about the structure and function of the cardiovascular and lymphatic systems. Forgive all the page flipping and water drinking sounds that you hear. But this is going to be a relatively straightforward presentation, and I think you're going to find it pretty easy to digest. So to begin, I want you to make sure that you have drawn out your heart like we practiced in class. So you should have a heart that you know where there's a clear left atrium, left ventricle, right atrium, right ventricle. You should have clear valves in between each of the different sections of the heart. You should have a set of lungs on there, and you should clearly draw the vessels that go from the heart to the lungs and from the lungs back into the heart. Again, you should have oxygenated versus deoxygenated blood highlighted, and the direction of blood flow highlighted. Okay, so have that ready to go now. If you need to pause this for a second, go right ahead. We're going to be working with it throughout. Okay, so the circulatory system, there's a lot of review in this PowerPoint, which is good, but you want to make sure that you have grasped it. Okay, first quiz. The blank ventricle pumps oxygenated blood to the body. Hopefully you said left. The blank ventricle pumps deoxygenated blood to the lungs. And of course, we're left with the right ventricle. Okay. So every term that you see in this PowerPoint, you need to know. Okay, every structure you need to know. You need to know its function. I'm only going to pick out certain ones to really accentuate. So the pericardium is one of them. The pericardium is not talked about as often. Okay, and if I were to ask you how would you explain to a patient what the pericardium is? It is a membranous sac that holds the heart. But the next big question is why? Why do we have a pericardium? What function does it serve? So think about all the bad things that can happen to our bodies, okay, specifically the heart. Why do you think the pericardium was created? To sit around our heart. So there's a few things that it does. Hopefully you thought about protection. Okay, the pericardium protects the heart from infections that are coming from other places. So the pericardium often will get infected first, saving the heart. Now, if the infection is coming through the bloodstream, the pericardium is not going to be able to stop that from hitting the heart, right? But generally, that's a very, very big function. It has pain receptors and stretch receptors, which can affect blood pressure and other things. And also, if you think about it, if you're moving around, flipping upside down and rolling around, it prevents displacement of the heart during acceleration and deceleration. Okay, so not something we think about often, but it actually holds your heart in place, which is important because there's only so much space in your body. Now the myocardium, as you know, we're talking about a muscle cardiac cell, okay? And it's a large, large part of the heart. And you'll see a better picture pretty soon. So the function of the pericardium is to protect the heart from infection and inflammation. The pericardium is a blank that encloses the heart. Membranous sac. True or false, the myocardium is made up of muscle tissue. True. Now, for that reason, also realize the myocardium can enlarge or atrophy. Okay, enlarging is one of the things that we'll talk about in a little bit from overworking of the heart. So take a look here at where the myocardium. So we talked about a lot of things, right? So here's the myocardium, right? And then there's some pericardial layers. There's a fibrous pericardium and there's a serous pericardium, okay? Now what's interesting about that is later on, next week, we're going to talk about pericarditis. Pericarditis is when there's inflammation in the pericardium layers. As you can see, there's more than one. And then they actually rub against each other and make this pericardial friction rub sound, which is really icky sounding, very scratchy. Okay. Now, when we're talking about an athlete who has overworked the heart at a young age and continuously for long distances, we can see a ventricular mass up to 60% greater than normal, than an untrained athlete. So who do you think would be the type of athletes that we would see this in? So long distance runners, certainly. Rowers, so long distance rowing, cross country skiers, and cyclists. They tend to have the largest left ventricular wall due to exercise. Now, we used to think that that was a great thing. Certainly, I remember that. But now the newer research is coming out, and there's a lot of concern for that change in the heart down the line. And so that's just something to think about. So that's a reason why some of these athletes actually have a lower pulse. Okay, so we all know 60 to 100 is normal. And a lot of these athletes over time, because their heart muscle becomes so effective, their heart rate will be in the 40s. And that's normal for them. It's just a very efficient heart, very strong, and pumps a lot of blood really fast. Okay. So we talked about, remember, away from the heart. So the pulmonary artery goes away from the heart, but it carries what kind of blood? Right? It's going to carry deoxygenated blood, pulmonary artery. Veins go towards the heart, like the pulmonary vein, right? Now all the other veins coming out from your legs and your arms are pulling in deoxygenated blood. So don't mix them up. Okay? Chambers of the heart, plenty for you to memorize here. Let's talk about the valves for a second. Okay. So in your picture, you should have drawn a few things. Okay. So you have your left atrium, your left ventricle, your right atrium, your right ventricle, and you have valves everywhere. Okay, so if I were to ask you, and here's the aorta and the pulmonary artery. So if I were to ask you, okay, where's the aortic valve? Pretty simple, right? You go to the aorta and see where it's leaving the heart, and that's the aortic valve. Okay, so then what if I said, where's the pulmonary semilunar valve? You would say, oh, well, clearly where the pulmonary artery leaves the heart, right? Okay, so easy. Now, what are the last two left? Okay, you have the tricuspid and the mitral. Now, there's a lot of ways that people remember them so they don't mix them up on exams. I like to remember tricuspid has RI in it for right. So RI for right, tricuspid right side. That means the mitral's on the left. Okay, doesn't matter how you remember it, but you do need to remember. Okay. Now, atrioventricular, very simple, right? Atrium and ventricle, something in between. Okay, there are some really neat flashcards and practice quizzes that you can take here, but a lot of this is reviewed for you guys. Okay, same thing. Okay, the great vessels. So the superior and inferior vena cava, right? So where are they going to dish blood to? Where are they dropping blood off? So hopefully you said the right atrium, We already talked about the pulmonary artery, pulmonary veins. Okay. And the aorta brings oxygenated blood where? The aorta brings oxygenated blood to the whole body. So what is the danger of an aortic aneurysm then? Aneurysm is a little outpouching of a weakened area of a vessel. I want you to think about what would happen if there was an outpouching of the aorta and it suddenly burst. Okay, that could mean very instant death for someone because again, this is all of your oxygenated blood. So depending where in the aorta and how quickly you lose blood, someone could not survive that. Okay, so a 40-year-old male develops a pulmonary embolism that occludes the pulmonary artery. As a result, blood would first back up into and the best answer is right ventricle. Okay, because you have to imagine the backup of blood, so use your heart. Pretty sure in health assessment you go over this, so I'm not going to spend a lot of time on this. So you have a systolic blood pressure and a diastolic blood pressure. You have systole and you have diastole. Okay, diastole is always going to be during the relaxation phase. Okay, pulling of the blood in the atrium after contraction has finished. And systole is always going to be when we're forcing blood out of the chambers during contraction. When you hear lub-dub, 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 what's actually making those sounds? And I suspect you know it already. Okay, so lub-dub, lub-dub. So during the lub sound, something is closing. And what is it? During the dub sound, something is closing. What is that? Okay, so hopefully you figured out the tricuspid and mitral valves close during the S1 or lub sound. Okay, and the other two valves close, so that's aortic and pulmonic, during the S2 or dub. Okay, lub dub. So between those two sounds, we have the process of systole. Okay, and then there's some time, and then lub dub, time, lub dub. So in between the lub dubs, the lub dub cycles is diastole. Okay? So there's always an explanation for sounds that you hear. It's important that you know them. Okay, in order for the left ventricle to contract, the pressure in the blank must exceed the pressure in the blank. So what needs to have greater pressure? The pressure in the left ventricle must exceed the pressure in the aorta. Okay, so that has to do with the afterload concept and some of the other pressures that we're talking about. But there is a certain amount of pressure in the aorta, okay, and the left ventricle has to be able to overcome that in order to get the ventricle open and actually pump the blood out. Okay, if the pressure in the aorta keeps increasing from a disease, okay, then the left ventricle has to work even harder, and eventually we could get heart failure, or we could get changes in that heart muscle because it has to keep exceeding this greater pressure. Okay, now the coronary vessels, I'm going to show you a quick video if I can get it up, just so you can see. So remember we talked about coronary vessels, so we always need blood to get to all of our organs, right? But we forget that the heart also needs blood, clearly.
In order for the heart to pump blood through the body, it first has to provide blood to itself so that it can obtain oxygen and nutrients. The myocardium is supplied with blood by two main coronary arteries that arise at the root of the aorta. The left main coronary, which then divides into the left descending and the circumflex, and the right main coronary artery. The main coronary arteries run along the surface of the heart as large epicardial arteries. They also send smaller branch arteries into the myocardium, the intramyocardial arteries. These further divide into a dense network of arterioles and capillaries.
Okay, so you can watch more of that video if you'd like. Okay, but that's basically the gist of it. So the blank artery travels down the interventricular septum and delivers blood to portions of the left and right ventricle. Okay, so the answer is the left anterior descending artery. Okay, and you can see just the left anterior descending artery here coming down and across. Okay, left coronary artery. Okay, pulmonary artery. So we've got a lot going on here, and as you can see, it's a very intricate network. So make sure you understand that. I want to mention collateral arteries are going to be used when? What do you think a collateral artery is for? So what is collateral? Collateral is like a guarantee, your backer, the security that something's going to happen, right? So collateral arteries are only used when necessary if something else is not working. So a primary artery and your collateral arteries are used more to ensure blood gets to the heart, because of course we need to have a backup system in case something happens, right? We can't just have the smallest blockage happen and then parts of the heart dies. And although that is possible, the collateral arteries help prevent that from happening so easily. Okay. The conduction system of the heart is very important. So when you think about the heart pumping, you're thinking, generally we think about the muscle, right? But there's a whole nother side of it. So yes, there's muscular contraction, needing oxygen and for the muscle, needing ATP for the muscle, okay? But actually in the heart, we're dealing with a whole system of electrical pulses, okay, that actually make everything happen. So if I asked you who or what is considered the pacemaker of the heart, what would be your best answer? The sinoatrial node, okay, or the SA node. That's considered the pacemaker of the heart. So that starts the electrical impulse, which then goes to the AV node, which then branches out and goes everywhere else. As the electrical impulse reaches different parts of the heart, we get contraction, okay? So when we're looking at an EKG, which is an electrocardiogram, we're looking at the electrical impulses only. We can't see the actual heart. We're just looking at the electrical impulses. So how do we see the heart? How do we see the chambers pumping? Okay, that's why we need an echocardiogram. Two different ways of looking at the heart. One shows electrical impulse, making sure all of that is working effectively. One shows the actual movement of the muscles. Okay. Now, if the SA node is our pacemaker, how many electrical impulses do you expect will be sent out per minute? Okay, so 60 to 100, right? Because a normal pulse is 60 to 100. So we should have about 60 to 100. 60 to 80 is sometimes used in the book, but you get the point. Okay, that's a normal pulse. When the SA node is working, we get a normal set of beats per minute. Now, what if the SA node all of a sudden, which you can kind of see it always starts up here. Okay, the SA node just isn't working at all. So no good. What happens? The AV node then has to end up starting the firing, the electrical impulses. And so how fast will the heart beat if the AV node is controlling that? So 40 to 60 beats per minute. And as each thing fails and you go further down, okay, as you go further down the chain, the beats per minute will get slower and slower. Those are two big ones I want you to know. So yes, you do need to understand all these words, okay? And there's good notes there to help you explain. So the electricity and the firing of a nerve is very simple, and it's very similar to the neurological system, which you're going to be learning soon. So you've got depolarization and repolarization. So depolarization is when you're going to actually, you're actually going to have movement, okay, of the actual electrical impulse. So, or the electrical impulse is created during depolarization. And repolarization is when you're returning back to that rest period, and the refractory period happens after that. Automaticity, or however you want to pronounce this word, okay, this means that we're not dealing with a voluntary motion. Okay, the heart doesn't beat voluntarily. The heart beats spontaneously with no stimulus. And what's really interesting about that is if you take certain heart muscle cells, okay, who are capable of creating electrical impulses, and you take them away from the heart and you put them in a dish, like a petri dish in a lab, they will actually generate electricity on their own. And if you put a clump of them together, one of them will take over and actually be the primary, I guess you could say, pacemaker. So it is an automatic situation that the cells are that advanced. Okay, so please review. Okay, now we just explained what depolarization is. Okay, and now you do need to have these memorized. You need to know for each wave what's happening in the heart. Okay. So the atrial depolarization. And again, this is talking about the electricity of the heart. This is not for sure saying that something's happening, but assuming the heart is healthy and it follows the instructions of the impulse, okay? So you have the atrium, both atrium depolarizing. Then you have the ventricles depolarizing, okay? And then the ventricles repolarizing, okay? Okay, good. So you do have to have this memorized, and so that you, so if I were to ask you, what's happening if this part is longer or if this part is missing or whatever, okay? The other thing we didn't talk about with the EKGs is the axes. So this axis here, so looking at this, is voltage. So you can see there's quite a large amount of voltage needed for both of the ventricles to contract. Okay, and then this axis is based on time. So it takes this amount of time for the atrial to depolarize, meaning for that electrical signal to get across the atrial, both the right and left atrium, takes that amount of time. Okay, same thing goes for the ventricles. So what do you think it means if all of a sudden ventricular depolarization takes twice as long? Okay, what if it spanned across this? That would be a very bad thing, wouldn't it? Because that means it's taking too long for that signal to get across. So we basically have a normal interval that we memorize when we have to interpret EKGs. I'm not going to make you memorize those right now, but down the line you may want to, especially if you're going to go into cardiac. And this is the normals. So let's see how well you know this. Which EKG segment represents the sum of all ventricular depolarization? Okay, the QRS wave. And which wave represents all atrial depolarization? The P wave. Very good. Now, why don't we see atrial repolarization anywhere? Right? We talked about all those other ones. Where's atrial repolarization? It's actually here within the QRS. It's just kind of hidden, and we don't spend a lot of time talking about it, okay? But the atria will have to repolarize just like the ventricles repolarize, okay? But it happens here. Okay, sympathetic, parasympathetic nerves. So we have nerves within the heart muscle who respond based on these two systems. So sympathetic is fight or flight. Parasympathetic is known as the rest or digest. Okay. What you need to know about that is sympathetic, you're looking at an increase in heart rate. Okay, so let's talk about fight or flight for a second. Okay, so you are a hunter, you're out in the woods, and you see a tiger. Your fight or flight kicks in. What happens to your heart? Okay, as you see that tiger, your heart starts beating out of your chest, right? Getting lots of oxygen everywhere, okay? What happens to your pupils? So they dilate to let in more light so you can see and get out, okay? Your energy starts moving forward. You have a lot of energy. Your blood gets shunted and diverted, I guess I should say, away from your non-essentials, like your GI tract, okay, over to your skeletal muscle, so that you can have your heart beating and you can move your muscles to escape. Okay, that's fight or flight. So your heart responds immediately to your sympathetic nervous system triggers. So you feel that probably a lot when you're in clinical or when you're taking an exam. Okay, and that's why your heart will change. Parasympathetic, you're going to have a slowdown of the heart rate. Okay, adrenergics, so we also have receptors that are open. Okay, if you open your hands and make receptors, these are receptors that are open to accept certain hormones that are released, such as epinephrine. So epinephrine, funny enough, also known as adrenaline, is often released with fear and anger. And you get an increased heart rate, you get increased muscle strength, increased blood pressure, and increased sugar metabolism. Just kind of interesting. Okay, the myocardial cells are really important. Do take a look at how that specific type of cell in the heart is made up. It's the most important one that I want you to focus on, and really look at the troponins. Okay, we already talked about some of that, but the main thing is if the heart cells are damaged and injured and dying, we're gonna see the troponins picked up in the blood. Okay, preload versus afterload. So there's another resource that I linked in your Sakai where there's some videos and things that might help you. Preload and afterload, you have to find a way to learn yourself because you can read the definitions a million times and it may or may not click. So the preload is the pressure at the end of diastole. Some people explain it. It's stretching prior to contraction. So it's almost like a balloon filling up. Okay, so that's the preload. The afterload is the pressure that the heart must work against to eject blood. Okay, so that's going to change depending on what's going on in the aorta, right? Like we talked about earlier. So what happens if the aortic pressure is increased? The afterload is going to be increased. Okay. So when we have if we have a dilated heart ventricle, the afterload can be increased. And so if that confuses you, that's fine. Hold that thought. But I do need you to spend some time really understanding this. This will be on all your exams. It's important for understanding the heart. Okay. Myocardial contractility, well, contraction, right? The contraction of the myocardium. I think that's pretty straightforward. The ability of the heart to contract affects how much volume comes out from each stroke. Inotropic agents, this will make more sense when you start learning about pharmacology. Okay, so there's inotropic medications such as digoxin. If you've heard of digoxin or dig, sometimes people say that. It strengthens the heart's contraction with less heartbeats. Okay, so anyway, good. There's pros and cons to that, but that's just an example. So sometimes we use that in patients that have had heart failure or after a heart attack. Okay, you do have to memorize this equation. Okay, and understand. So cardiac output equals stroke volume times heart rate. Okay, and what's the length of time we're talking about? Minute, right? A minute. So milliliters per minute is what we're shooting for. So if I were to tell you the stroke volume was 70 and the heart rate was 85, and you were to take a calculator out, okay, think you're going to get 5,950 milliliters per minute. Right. So arterioles are baby arteries, venules are baby veins. Okay, capillaries are mixed between the arterioles and the venules. So you've got both systems going, deoxygenated and oxygenated mixing in the capillaries as perfusion occurs. So let's review. Okay, more review about the vessels, which you've already read about. Shouldn't be new. Okay. I guess what I want to mention here is that your endothelium, right, for your vessels, it's flexible and it stretches and opens and closes as needed. Okay, imagine this beautiful, flexible, sensitive vessel. So how do you think the endothelium responds to stress and smoking? Okay, if you can imagine, with blood pressure going up, it tends to constrict. Okay, perhaps with meditation and deep breathing, it can change. Okay, but that's just a review because the endothelium goes everywhere. Okay, structure of the blood vessels. Veins are very thin-walled. They have a larger diameter. They're more numerous, and they're shallow on the body. So if you can see, there's a lot of valves, and as you start to do IV insertions, you're gonna every once in a while hit what they say you're hitting a valve, and the vessel will actually close up, and you'll get this pocket of blood pooling there. And sometimes you have to do something to kind of trick the body into letting you through with your IV. Sometimes heat, sometimes removing the catheter a little bit. Anyway, things to look forward to as you do IVs. But do realize there's valves all over the place. Okay. There's muscles surrounding the vessels so that we can cause constriction. Okay. Vasoconstriction, vasodilation. Okay. Imagine what this would do to your blood pressure and what this would do to your blood pressure if it opened up. Okay. So I do want you to go through and review the resistance. And I want you to figure out when is resistance going to be increased, okay? When you have a bigger versus a smaller diameter, a longer versus a shorter length of the blood vessel. So go back and make sure that you understand that well. Draw a larger diameter and a smaller diameter. Draw a shorter vessel and a longer vessel. And figure out which one is going to have more resistance. And your book will guide you through that. Okay, lots of factors affecting blood flow. So diameter of the vessels obviously is important. Baroreceptors are stretch receptors. Chemoreceptors are going to pick up carbon dioxide and oxygen. Okay, so all of those things are constantly monitoring the environment to determine how much blood flow is needed, whether it needs to be kicked up a bit. Okay, you do need to know this equation as well. Okay, peripheral resistance times cardiac output for blood pressure. Okay, that being said, you also need to understand the RAAS system, the Renin-angiotensin-aldosterone system, and how that affects blood pressure. Okay, so the RAAS system, while I don't have that, oh, here it is. Okay, so I need you to understand this. This is going to be a review next semester, but I need you to understand it now because this system, while it looks complicated, once you have it memorized, you understand blood pressure a lot better. And blood pressure is a very important concept with cardiovascular. So you need to start reviewing this now. So my question would be, what would trigger the system to kick in? Okay, what would trigger it to kick in is if you had a low blood pressure. Okay, because when the renin-angiotensin-aldosterone system kicks in, it actually increases your blood pressure as the end result. Okay. Now, there's many sections here, and if one piece goes wrong, we may not have that end result that we want. Okay, a lot of your medications for blood pressure are actually going to be affecting parts of the system. For example, an ACE inhibitor, okay, is going to work here and block this, inhibiting the ACE, so that you don't get the increase in blood pressure at the end. So anyway, it's very interesting. It's all going to come together, but I'm telling you now that this is something you need to know. Okay. A little review on the lymphatic system. So we haven't talked a lot about the lymph fluid, but this is a very specialized system. It's considered a vascular system. It picks up fluid and returns it to the bloodstream. So there's lymphatic veins and venules. Okay. So if you remove all the lymph vessels and nodes on one side, for example, okay, if you've seen someone who's had a mastectomy on one side and their one arm is swollen and the swelling is permanent, it's always there on that arm and that side. You can't take a blood pressure over on that side. So they've had lymph vessels and lymph nodes removed on that arm. Because of that, they don't have the lymph system pulling fluid in, the excess fluid in and putting it back to the bloodstream. That's why you have that permanent swelling, and they have to wear special type of arm compression sleeves to keep the fluid down. And that will be forever while those lymph nodes have been removed. Okay, so that's enough for you to study for now. So I do expect that you're going to do a good job on that, and I will talk to you guys soon. Thanks a lot.